So hello everyone, my name is Dr. Sikandar and today we will discuss about the prevention and maintenance treatment of patients with COPD. So this is like part 2 of gold guidelines for COPD. First thing is smoking cessation. A significant proportion of people with COPD continue to smoke despite they know that they have the disease. So they are telling like 40% of the patients with COPD are current smokers. So this behavior usually negatively impact the prognosis and the progression of the disease. And smoking cessation has the greatest capacity to influence the natural history of COPD. So smoking cessation is very much necessary in case of COPD. They are telling there are a lot of approaches and individual approach to tell the patient to stop the smoking, and like legislative smoking bans are effective in increasing quit rates. So now we will discuss about the vaccination for stable COPD patients. So we already know like influenza vaccination, COVID vaccination, these are recommended in patients with COPD, and they are telling like 20-valent pneumococcal conjugate vaccine or 15-valent pneumococcal vaccine. They are advised, followed by 23-valent pneumococcal polysaccharide vaccine in people with COPD. So now they are telling like this is the new changes. What are these new changes? The CDC recommend like TDAP vaccination to protect against pertussis, whooping cough, for the people with COPD that were not vaccinated in the adolescent. So the people who have not vaccinated during adolescence life, so they have to be given TDAP vaccine, and the zoster vaccine to protect against shingles to people with COPD more than 50 year of the age. Now they are telling what are the commonly used maintenance medications in COPD patients. So like they are telling a lot of drugs are there. First thing is beta agonist. So beta agonist could be short acting or it could be long acting. In short acting there are phenoterol, leva, levalbuterol, salbutamol, and terbitalin. So these are like short acting beta agonist. So they used to act around like 4 to 6 hours, most of them. Then comes long acting beta agonist. Those are formoterol, L-formoterol, indacaterol, olodaterol, and salmeterol. And these all drugs like usually act around 12 to 14 hours. And endacaterol and oladaterol, these used to act for 24 hours, like for maximum. Endacaterol and olodaterol. Then comes Sama and Lama, like short-acting muscarinic antagonist. So what are these anticholinergics? Samaj, ipratropium bromide and oxytropium bromide, and these used to act around 6 to 9 hours. Then comes Lama. These contain aclinidium, glycopyrrolinium, tiotropium, omeclidinium, glycopyrrolate, and revifenacin. So these drugs used to act around like 12 to 24 hours. Then comes like combination of SABA and SAMA. These are like phenoterol and ipratropium combination, salbutamol and ipratropium combination. Then comes like LABA and LAMA. So these drugs are like formoterol and aclidinium, formoterol and glycopyrronium, endacaterol and glycopyrronium, vilanterol and omeclidinium, olodaterol and tiotropium. So these used to act around like 12 to 24 hours. Then comes methyl xanthines. So methyl xanthines are like aminophylline and theophylline. Aminophylline is available in solution form, and theophylline slowly releasing is available in the pill form. And these drugs used to act around 24 hours. So then comes like a combination of LABA and like inhaled corticosteroids. And these are like formoterol, beclomethasone, formoterol budesonide, formoterol mometasone, salmeterol fluticasone, vilanterol fluticasone. And these used to act around 12 to 24 hours. So vilanterol and fluticasone is like most long-acting DPI, which is like for 24 hours. Then comes triple combination in one device. So these are like fluticasone, omeclidinium, and vilanterol combination of DPI for 24 hours. Then comes veclamethasone and formoterol and glycopyrronium combination of MDI and DPI, which used to act for 12 hours. And then comes budesonide, formoterol, and glycopyrrolate combination of MDI, which used to act for 12 hours. Then comes phosphodiesterase 4 inhibitor, which is roflumilast. Roflumilast is available in the pill form, and it used to act for 24 hours. Then comes mucolytic agents, which are aldocysteine, carbocysteine, and N-acetylcysteine, and these all are available in the pill form, and these used to act around 12 hours. Now we will discuss individual components separately. First thing is beta 2 agonist. So what is the like beta 2 agonist? The principal action of beta 2 agonist is to relax airway smooth muscle by stimulating beta 2 adrenergic receptor, which increase cyclic AMP and produce functional antagonism to bronchoconstriction. Means these used to do bronchodilation. And there are short-acting SABA and long-acting beta agonists. The effect of SABA usually wear off within 4 to 6 hours. Regular and as-needed use of SABA improve FEV1 and symptoms. LABA shows duration of action for 12 hours or more, and do not preclude additional benefit from as-needed SABA therapy. So there is no extra benefit except like duration of action of LABA. Now they are telling like formoterol and salmeterol are twice daily lavage that significantly improve FEV1 and lung volume and dyspnea and health status, exacerbation rate and number of hospitalization. So like formoterol and salmeterol, which are the twice daily using lavage, these are like very beneficial, but they do not have any effect on mortality. Indacaterol is a once daily using lava, so it is like more acting, like more prolonged acting lava. Indacaterol is once daily using lava that improve breathlessness, health status and exacerbation rate. Some patients experience cough following the inhalation of indacaterol. So following the inhalation of indacaterol, some patients used to feel experience cough, and they are telling like Ola, Dator and Vilantrol are additional once daily lava that improve lung function and symptoms. So we should like know that indacaterol used to do like produce cough. It used to aggravate cough. Okay. Then comes like what are the adverse effect of these like beta 2 agonist. So they are telling like they can do like resting sinus tachycardia. They can precipitate cardiac rhythm disturbance, exaggerate somatic tremors. They can cause hypokalemia. So hypokalemia can worsen in the case of thyroid diuretics. As we know, thyroid diuretics also causes hypokalemia. So they are telling if we are giving thyroid diuretics, then we should like cautiously use beta 2 agonist because they can do hypokalemia. And they are telling like these metabolic effect used to get decreased with time. So this thing is known as tachyphylaxis. So tachyphylaxis is shown by beta 2 agonist. Very, very important. Now we will come to anti-muscarinic drugs. So what are the anticholinergic drugs? So they are telling these drugs used to act on M3 muscarinic receptors, which are expressed in airway smooth muscles. So these could be short acting or long acting. So they are telling like short acting SAMA, namely ipratropium and oxytropium, also blocks the inhibitory neural receptor M2. So they are telling like these SAMA also they will used to block M3 receptors, but as well they also inhibit neuronal receptor M2, which potentially causes vagally induced bronchoconstriction. So by vagus nerve, it used to cause bronchoconstriction by M2 receptors. So that's why they are telling like long-acting muscarinic antagonists like LAMA, such as tiotropium, aclidinium, glycopyrronium bromide, also known as glycopyrrolate, and omeclidinium have prolonged binding to M3 muscarinic receptor with faster dissociation from M2 receptors, thus prolonging the duration of bronchodilator effect. So they are telling like LAMA are like long-acting muscarinic antagonists are more beneficial because they used to prolongly act on M3 receptor and they used to dissociate earlier from M2 receptors. That's why bronchodilate some effect is more than bronchoconstriction effect. Then comes what are the adverse effect of these anticholinergic drugs. So they are telling like inhaled anticholinergic drugs are poorly absorbed. So by inhalational route, they used to get poorly absorbed. And the main side effect is dryness of the mouth. So dryness of the mouth is the main side effect of these inhaled anticholinergic drugs. And they are telling like occasionally they can cause urinary symptoms. They can unexpectedly increase cardiovascular events. And they are telling like use of solution with face mask can precipitate acute glaucoma. So they are telling like it can because these are mydriatrics and these can precipitate the glaucoma. So we should avoid the face mask if patient is high risk for glaucoma episode. So they are telling like what are the methylxanthines. So we have discussed SABA, then we have discussed beta agonist, then we have discussed anti-muscarinic agents, and now we are discussing methylxanthines. So we already know like these methylxanthines used to act by non-selectively on phosphodiesterase enzyme, and these are like non-selective phosphodiesterase inhibitors, non-selective phosphodiesterase inhibitors. And these contain like there are two kind of drugs. First is theophylline and second is aminophylline. So they are telling theophylline, the most commonly used methylxanthine, is metabolized by cytochrome P450 mixed function oxidases, and they are telling like clearance of this drug declined with the age, and many other physiological variables and drug modify theophylline metabolism. So like we have to be cautious for use of theophylline with a lot of drugs. So they are telling like there is evidence for modest bronchodilator effect compared with placebo in a stable patient of COPD. So like it is useful. Addition of theophylline with salmeterol produce a greater improvement in FEV1 and breathlessness than salmeterol alone. So it is like very good uh, if we are using it with long-acting beta agonist, salmeterol. Then they are telling like what are the side effects of these theophylline or methylgenthins. So they are telling ventricular arrhythmias are like side effect. Then it can cause grand mal convulsions. So epilepsy can be caused by it. Other side effects are headache, insomnia, nausea, heartburn. And then they are telling like these medications have significant interaction with commonly used medications such as erythromycin. So we should not use erythromycin with methylgenthins or theophylline, but we can use azithromycin. Certain quinolone antibiotic like ciprofloxacin we can't use, but not we can use ofloxacin, but not ciprofloxacin. And with allopurinol, cimetidine, and SSRI, we have to be cautious. And 5-lipoxygenase inhibitor like xylutine, we have to be cautious to use the theophylline. Then they are telling about the combination bronchodilator therapy. So they are telling combining bronchodilators with different mechanism and duration of action may increase the degree of bronchodilation with the lower risk of side effect compared to increasing dose of the single bronchodilator. If we will increase the dose of single bronchodilator, then there are more chances of having side effect rather than we can use multiple drugs and in limited dose. So they are telling treatment with formoterol and tiotropium in separate inhaler has a bigger impact on FEV1. And there are numerous combinations of LAVA and LAMA available in single inhaler. And these combinations improve the lung function compared to placebo. And the LAMA-LAVA combination demonstrates favorable improvement compared with monotherapy for majority of outcomes. So these findings has shown in people across the different ethnic groups. So there is not like study has not been like throughout the world. So yeah, but like now they are telling like in another study in a population with high exacerbation risk, like more than two exacerbation or history of one hospitalization in previous year, reported that LAVA plus ICS, inhaled corticosteroid, decreases the exacerbation to greater extent than LAVA and LAMA combination at higher blood eosinophilic concentration. So they are telling if there are like high blood eosinophilic counts, then we should use inhaled corticosteroids, and these inhaled corticosteroid can increase the risk of pneumonia. So this is also like we have to remember. This is the disadvantage of using inhaled corticosteroids. Then comes like bronchodilators in stable patient with COPD. So there are multiple evidences. We will discuss them one by one. First thing is like inhaled bronchodilator in COPD are central to symptom management and commonly given on regular basis to prevent and reduce the symptoms. So we use inhaled bronchodilators. Then they are telling regular as needed use of SABA and SAMA improve FEV1 and symptoms. Combination of SABA and SAMA are superior to like either medication alone. So like combination is way better than alone. Then they are telling me LAMA and LAMA significantly improve the functions. Already we know LAMA have a greater effect on exacerbation, and it is better than LAMA. So LAMA is better than LAVA. So we should know these things also. And they are telling like LAMA and LAMA combination is better than compared with monotherapy. Yeah. And now they are telling like combination treatment with LAMA and LAVA reduces exacerbation compared to monotherapy. Already we know. Tiotropium improve the effectiveness of pulmonary rehabilitation and increasing exercise performance. Okay. Then they are telling theophylline exert a small bronchodilator effect on stable COPD, and that is associated with modest symptomatic benefit. Single inhaler therapy may be more convenient and effective than multiple inhalers. So we should use single inhaler therapy. So means multiple drugs should be available in a single inhaler. Now they are telling like anti-inflammatory therapy in the stable patient of COPD. So inhaled corticosteroids. And inhaled corticosteroid combined with LABA is more effective than individual component, as we have already discussed. ICS, so they are telling like inhaled corticosteroid are like better in exacerbation and moderate to very severe COPD patients. And regular treatment with inhaled corticosteroid increases the risk of pneumonia. We have already discussed. Lower blood or sputum level of eosinophil are associated with greater presence of proteobacteria like Haemophilus, and it increases the bacterial infection and pneumonia. So they are telling if eosinophils level is reduced, then proteobacteria level will be high, and like Haemophilus level will be higher, and which lead to increased bacterial infection and pneumonia. And now they are telling like independent ICS use. There is a evidence that blood eosinophilic count less than 2% increases the risk of pneumonia. So if blood eosinophilic counts will be more, then pneumonia risk will be less. If blood eosinophil count is less, then pneumonia risk will be higher. Triple inhaled therapy of LABA, LAMA, and ICS improves lung function, symptoms, health status, and reduces exacerbation compared to LABA ICS combination or LABA LAMA or LAMA monotherapy. And they are telling single inhaler therapy may be more convenient and effective than multiple inhaler. And they are telling about the oral glucocorticoids. Longer term use of oral glucocorticoids has numerous side effects with no evidence of benefit. So we should not use oral glucocorticoids. We should use inhaled glucocorticoids. Now they are telling about phosphodiesterase 4 inhibitors in patient with chronic bronchitis. Yeah, we should remember this word also. Like in patient with chronic bronchitis and severe to very severe cases of COPD and history of exacerbation. So they are telling a PDE4 inhibitor improve lung function and reduce moderate to severe exacerbation. And PDE4 inhibitor improve lung function and decreases exacerbation in patients who are on fixed dose of LAVA and ICS combination. So like patient is already taking LAVA and ICS combination, uh, and like he is on like moderate to severe, he is having moderate to severe exacerbations. So like in those cases, phosphodiesterase 4 inhibitors like roflumilast is like good option. Then they are talking about antibiotics. So long-term azithromycin and erythromycin therapy reduces exacerbation over the 1 year. So we should use it for 1 year. Only then they can improve, reduce exacerbation. Treatment with azithromycin is associated with increased incidence of bacterial resistance. And in hearing, it can impair the hearing like test, and it used to do QT prolongation. They are telling about like mucoregulator and antioxidant therapy like erdocystine, carbocysteine, and N-acetylcysteine reduces the risk of exacerbation in selected population. Other anti-inflammatory agent like simvastatin has not like a greater effect, but yeah, it is having like positive effect in patients with who are having any like cardiovascular indications. They are telling like leukotriene modifiers have not been tested adequately in COPD patients. So now they are again talking about the inhaled corticosteroids. So they are telling in vitro evidence suggests that COPD associated inflammation has limited responsiveness to corticosteroid. Moreover, some drug-induced, including beta-2 agonist theophylline macrolide, may partially facilitate corticosteroid sensitivity to COPD. So they are telling, like, if we are using inhaled corticosteroid with these drugs, so these drugs used to increase the effect of corticosteroids in patients with COPD. So clinical relevance of this effect has not yet been fully established. In vivo data suggests that dose response relationship with long-term, like for more than 3 years, safety of inhaled corticosteroid in people with COPD are unclear and require further investigation. Okay, both current and ex-smokers with COPD benefit from ICS in term of lung function and exacerbations. So they are telling like efficacy of ICS is not that great in improving FEV1 or mortality in patient with COPD. But if we are using ICS in patient with who is already taking long-acting bronchodilator therapy. So they are telling in patient with moderate to severe COPD and exacerbation, inhaled corticosteroid combination with LAVA is more effective than either component alone. Most studies have found like there is a beneficial effect of LAVA and ICS, fixed dose combination of over LAVA alone. So like what is the role of blood eosinophilic count? They are telling blood eosinophilic count predict the magnitude of effect of ICS. Will ICS will be effective for that this in the COPD patient or not. So they are telling there is like continuous relationship between blood eosinophilic count and inhaled corticosteroid effect. Indicate that inhaled corticosteroid containing regimen have little or no effect at a blood eosinophilic count less than 100 cell per microgram. Therefore, this threshold can be used to identify patient with low likelihood treatment benefit with ICS. So they are telling blood and sputum eosinophils are associated with greater presence of proteobacteria. We have already discussed like Haemophilus and are increased bacterial infection and pneumonia. So if blood and sputum eosinophil will be less, then there will be increased presence of proteobacteria like Haemophilus, and there will be increased chances of pneumonia. Lower blood eosinophil count therefore may identify individual with microbiome profile associated with increased risk of clinical worsening and pathogenic bacterial species. The threshold of blood eosinophilic count more than 300 cells per microliter identify the top of continuous relationship between eosinophil and inhaled corticosteroid and can be used to identify patient with greatest likelihood to treatment benefit with ICS. So they are telling like if patient is having blood eosinophil count more than 300 cells per microliter, then uh, he will be like benefited with this inhaled corticosteroid very like uh, there are like good chances of improvement. So there is evidence that on average blood eosinophilic counts are higher in COPD patients, and there is high level of type 2 inflammation markers will be there related to like COPD in patients with COPD. So they are telling like threshold of less than 100 cells and more than 300 cells should be regarded as estimates. These are like cutoff values. Less than 100 or 300. If it is less than 300, then we should not use inhaled corticosteroid. If it is more than 300, like then we should strongly recommend the use of inhaled corticosteroid. So they are telling the treatment effect of inhaled corticosteroid containing regimen like LABA, LAMA plus ICS or LAVA plus ICS versus LAVA and LAMA is higher in patients with high exacerbation risk, like more than 2 exacerbation or more than if there is any history of hospitalization previous year. So yeah, now they are telling about the adverse effect of inhaled corticosteroid. So they are telling there is high quality evidence with RCT that inhaled corticosteroid use modify the airway microbiome. So it used to modify airway microbiome, which is like good for our airway. So it will lead to higher prevalence of oral candidiasis, hoarseness of voice, skin bruising, and pneumonia. And they are telling like patients at higher risk of pneumonia include what patient like which patient will be like on higher risk. So they are telling the patients who currently are smokers and whose age are like more than 55 years have a history of prior exacerbation of pneumonia and BMI less than 20 kilogram per meter square and a poor MRC dyspnea grade or severe airflow obstruction is there. So there are a lot of component like current smoker, age more than 55 year, history of prior exacerbation of pneumonia, BMI less than 25, and poor MMRC grade dyspnea or severe airflow obstruction. So independent of ICS use, there is evidence that blood eosinophil count less than 2% increases the risk of developing pneumonia. So this is also a like independent risk factor for development of pneumonia, like blood eosinophilic count less than 2%. Now they are telling like it also increases the bone density, sorry, decreases the bone density, so increases the chances of fracture, and it also like increases the risk of poor control of diabetes, cataract, mycobacterial infection, and increased risk of tuberculosis. So yeah, now they are telling what are the factors to consider when initiating inhaled corticosteroid treatment. So factor to consider when adding inhaled corticosteroid, if we are adding them with long-acting bronchodilators. So what are those factors? So they are telling like what are the strongly favoring things. So they are telling history of hospitalization for exacerbation of COPD, more two or more than two moderate exacerbation of COPD per year, blood eosinophilic count more than 300 cells per microliter, history of concomitant asthma, and what like favors the use one moderate exacerbation of COPD per year and 100 to 300 cells per microliter, and what are the factors which are against the use of ICS. So those are like repeated pneumonia event, we know like it used to increase the chances of pneumonia, blood eosinophilic count less than 100 and history of mycobacterial infection, so it used to increase the chances of pulmonary tuberculosis. So that's why if there is any history of mycobacterial infection, blood eosinophil count less than 100 and repeatedly pneumonia infection is there, then we should not use these inhaled corticosteroid. Now they are telling like about yeah, they are again telling the same thing. Now what oral corticosteroids? So they are telling like there are a lot of side effects of oral glucocorticoids. So first thing is like steroid myopathy. So it used to cause steroid myopathy, which can contribute to muscle weakness, decreased functionality, respiratory failure in people with very severe COPD, and systemic glucocorticosteroids for treating acute exacerbation in hospitalized patient or during emergency department visit. Reduce the rate of treatment failure and rate of relapse and improve the lung function and breathlessness. So yeah, in the patients with severe COPD, we can use these oral glucocorticosteroids. So we should like know these things very well. So systemic glucocorticoids for treating acute exacerbation in hospitalized patient or during emergency department visits have been shown to reduce the risk. So these used to reduce the risk of treatment failure. Very, very important. So it used to reduce the rate of treatment failure and the rate of relapse and improve the lung function and breathlessness. So yeah, very, very important. So it used to improve the lung function and breathlessness and decrease the rate of relapse and reduce the rate of treatment failure. Very, very important. So why we should use these systemic glucocorticosteroid in acute exacerbation of COPD and during emergency visits. Yeah. Now they are telling like if oral glucocorticoids have no role, these drugs have no role in chronic daily treatment in COPD. So we should not use these oral glucocorticosteroids for chronic daily use in COPD patient because it used to have like a higher rate of systemic complications, as we have already discussed. These all things like steroid myopathy, muscle weakness, decreased functionality, respiratory failure, like that. Now comes phosphodiesterase 4 inhibitors. So we already knows like it used to reduce inflammation by inhibiting breakdown of CAMP. So it used to increase the level of CAMP. And roflumilast is the classical example of PD4 inhibitor, and we used to use in once daily dose. And they are telling like it is good in moderate to severe exacerbations. So it is good in moderate to severe exacerbation, and like in patients with chronic bronchitis and severe to very severe COPD and history of exacerbations. So what are the side effects of PD4 inhibitors? So they are telling most frequent side effects are diarrhea, nausea, reduced appetite, weight loss, abdominal pain, sleep disturbance, and headache. And they are telling like these side effects are present only in during early part of treatment, and these are reversible. But they are telling like weight loss is unexplained, and like it could be till 2 kg. So weight monitoring during treatment is advised, very very important. If we are using phosphodiesterase inhibitor, so weight monitoring is advised, very very important. Yeah. And they are telling like it can lead to depression also in some patients. So what about antibiotics? So they are telling like azithromycin 250 milligram per day or 500 milligram thrice 3 times per week, or erythromycin 250 milligram twice uh, per day for 1 year in patients prone to exacerbations, reduces the risk of exacerbation compared to usual care. Azithromycin use was associated with increased incidence of bacterial resistance, we already know, and prolonged QT interval. So it used to cause QT prolongation, QTC prolongation, very important, impaired hearing test. So yeah, these are like side effect of azithromycin. And what about mucolytics? So they are telling like regular treatment with mucolytics such as carbocysteine and acetylcysteine may reduce exacerbation and modestly improve the health status. So other drugs which have potential to reduce exacerbation, they are telling about the anti-IL-5 monoclonal antibody mepolizumab and anti-IL-5 receptor alpha antibody benralizumab. This is like receptor. This is anti-IL-5 receptor alpha antibody. So they are telling like in study has shown like in 50 to 20% reduction in rate of severe exacerbation, but effect was not statistically significant with these drugs. So they are telling like we have like in recent study like mepolizumab has like good role in patients with eosinophilic COPD and frequent requirement of oral, if those who are having like frequent requirement of oral corticosteroid, then mepolizumab has very good role. What about nidopromil and leukotriene and modifiers? They have not like there is no evidence till now to use the nidopromil and leukotriene in modifiers, and no evidence about infliximab and metoprolol also. Then comes simvastatin. We knows about it like particularly it does not have any role in preventing exacerbations, but in patients who are already taking simvastatin for like cardiovascular or metabolic indications, those patients have like good role in improving exacerbations. So, and like what about vitamin D? They are telling in a meta-analysis, vitamin D supplementation reduces exacerbation rate in patients with low baseline vitamin D level. Like only those patients who are already having low vitamin D level, those are having decrease the chance of exacerbation with vitamin D supplementation. So they are now they are talking about some trial. So what about those trials? So they are telling like they are like Torch clinical trial was there, then Summit trial was there, and those trials were like for LAVA and ICS. But those these have shown like there is no decrease in mortality with these drugs, LAVA and ICS. But recently, evidence has emerged that two large randomized clinical trials like IMPACT and ETHOS, that fixed dose inhaled triple combination like LABA plus LAMA plus ICS reduces all-cause mortality compared to dual inhaled long-acting bronchodilation therapy. These trials were enriched for symptomatic patients like CAT more than 10 with history of CAT. We know like COPD assessment test more than scoring more than 10 with a history of frequent means more than two moderate exacerbation and only one severe exacerbation or one episode of like hospital admission. So in those cases, like triple combination has very good role. What about non-pharmacological therapy? So we know like smoking cessation has like very good role, and overall it reduces the mortality. And what about the pulmonary rehabilitation? They are telling like was associated with statistically significant reduction in the mortality. Then comes like what about the long-term oxygen therapy? So they are telling like survival benefit with long-term oxygen therapy in COPD demonstrated two studies. So they are telling like 2 RCT in the COPD patient with resting PaO2 less than 55 or less than 60 with core pulmonale or secondary polycythemia showed a survival benefit. So yeah, in few selected patient, long-term oxygen therapy has a good role. Like what is the long-term oxygen therapy? So they are telling like use of oxygen for more than 19 hours of like continuous oxygen, or like more than 15 hours according to MRC. And what about the NIV, non-invasive positive pressure ventilation? They are telling like recent meta-analysis has shown positive result of long-term and PPV in patients with stable COPD. So in those patients with who are already having like marked hypercapnia and applying higher IPAP level demonstrated reduction in mortality. And they are telling about the lung transplantation, like they have no not like good data, but they have observed data has been shown to estimate survival benefit of lung transplantation relative to remaining untransplanted patients. So yeah, if transplantation has been done, then it has a good role, but a proper data is not available because a lot of transplantation has not been done till now. So what about other pharmacological treatment? So they are telling alpha-1 antitrypsin augmentation therapy. So it may slow down the progression of emphysema if we are using it intravenously. What about antitussive? So it has no conclusive evidence of beneficial role of antitussive in people with COPD. And vasodilators, they can worsen the requirement of oxygenation. So we should not use vasodilators. So here are like few key points. I will just read them. Smoking cessation. Yeah. Smoking cessation is key. Nicotine replacement and pharmacotherapy reliably increase long-term smoking abstinence rate. Legislative smoking bans and counseling delivered by the healthcare professional improve the quit rate. There is no evidence to support the effectiveness and safety of e-cigarette, so we should not use e-cigarette as a smoking cessation aid at present. Pharmacological therapy can reduce COPD symptoms, reduces the frequency and severity of exacerbations, and improve the health status, exercise tolerance. Data suggest beneficial effect on rate of lung function and decline the mortality. Each pharmacological treatment regimen should be individualized and guided by the severity of symptoms, risk of exacerbation and side effect and comorbidities, drug availability and cost, and the patient's response, preference, and ability to use various drug delivery devices. Inhaler technique need to be assessed regularly. COVID-19 vaccination are highly effective against SARS-CoV-2 infection, and patients with COPD should have COVID-19 vaccination in line with national recommendations. Influenza vaccination decreases the incidence of lower respiratory tract infection. Pneumococcal vaccination decreases the incidence of lower respiratory tract infection. And they are telling like CDC recommended Tdap vaccination, pertussis, tetanus, and diphtheria for COPD patients who were not vaccinated in adolescent. Very very important. Only those patients who have not vaccinated in adolescent's life, as well as routine use of singles vaccination in all COPD patients more than 50 years of age. Then they are telling pulmonary rehabilitation with its core component including exercise training combined with disease-specific education improves exercise capacity, symptoms, and quality of life across all grade of COPD severity. In patient with severe resting chronic hypoxemia like PaO2 less than 55 or less than 60, if there is core pulmonale or secondary polycythemia, then we should use long-term oxygen therapy. Means long-term oxygen therapy improve the survival in these patients. Like PaO2 less than 55 or less than 60 if he's having core pulmonale or secondary polycythemia. Means they are having like severe resting chronic hypoxemia. Very very important. In patient with stable COPD in resting or exercise-induced moderate desaturation, long-term oxygen therapy should not prescribed routinely. However, individual patient factor must be considered when evaluating the patient's need for supplemental oxygen. In patients with severe chronic hypercapnia and a history of hospitalization for acute respiratory failure, long-term non-invasive ventilation may decrease the mortality and prevent rehospitalization. So long-term non-invasive ventilation should be given if patient is having severe chronic hypercapnia and a history of hospitalization for acute respiratory failure. In selected patients with advanced emphysema refractory to optimized medical care or surgical or bronchoscopic intervention, treatment may be beneficial. Palliative approaches are effective in controlling symptoms in advanced cases of COPD. So that's it for second part of gold guidelines, guys. Good night.